Thank you very much. Good evening, everyone. So nice to be here. I have a lot of information to share with you tonight. So I may go through the slides a little bit fast, but we'll definitely leave time for questions. And I'm happy to share my email address at Tufts at the end in case you have some follow-up questions. So what we're going to cover tonight is, first of all, why should we even worry about childhood obesity prevention? And I want to share some work I did almost a decade ago looking at other models of social change that we've realized in the U.S. and talk about what we can learn from those. Then I'll move into a systems approach or perspective, which is what I'm using now to frame the work that I'm doing. And I'll talk about the Shape Up Somerville intervention, which was a successful intervention that I conducted in the city of Somerville outside of Boston. And I'm going to talk about that in the context of a 10-year period, and I think it'll make sense when I tell the story. Although the intervention was a 3-year study, the work that I did in Somerville, and I continue to do, is really a 10-year story. And I'll talk about the ingredients for success to work at the community level and try to prevent childhood obesity. And then I'll end with some recommendations to use that you can apply to your everyday lives, either in a work environment you may be in dealing with children or grandchildren, or just as an active citizen in your own community. So starting with a little bit of background. I'm a scientist at Tufts, and I study predominantly childhood obesity these days. And I've been working in the field for almost 20 years, started my work in bone health, looking at osteoporosis prevention. And many of us refer to osteoporosis as a pediatric disease with geriatric outcomes. I'm not sure if you've heard that before. But the reason is because you build most of your bone before the age of 25. In fact, the majority of it is laid down by your 16th year. And so if you fail to lay it down, you can end up with suboptimal levels of bone and develop bone loss quite early, which could lead to a diagnosis of osteopenia or osteoporosis in your 40s or 50s rather than perhaps in your 70s or 80s. So that's really how I began my journey. In my first NIH-funded study, we measured not only the bone of the children, but we measured their heights and weights. And it was right about the time when the childhood obesity epidemic hit the airwaves, and America became aware that it was a big problem. And I had my own data showing the same thing, particularly in underserved children in eastern Massachusetts. And so I've gone on to conduct several large trials now, really focused on obesity prevention. And I'm one of many researchers around the country studying childhood obesity. And before me, there were decades of studies going on that have informed the current generation of thinking. So what I'm sharing with you today is the approach that I'm taking, but also the approach that many others are taking who work in the area of childhood obesity. And many of us believe that obesity-related behaviors are not only a matter of individual choice, but they're strongly influenced by the socio-environmental systems that are interacting around us simultaneously. So, for example, the reason that you might choose a particular dessert tonight is because it's there. It's being provided to you in this particular environment. And if the portion size is big, you'll probably eat it because it's there. So the environmental influences and cues and the policies that we've set up in this country are dictating the way that we behave. It's not to say that individual choice isn't important in the equation, but I work predominantly in low-income, disadvantaged communities across America. And when there's no supermarket and no park, and the school food being provided for breakfast and lunch is high-fat, high-sodium food, it's not really a matter of individual choice. So many of us believe that we have to change the systems that surround us to make a difference in individual health, accompanied by individual education and practicing appropriate behaviors. So therefore, community, environmental, and policy-based interventions, which are different from individual one-on-one interventions, which historically we did a lot of, are creating a paradigm shift and really paving the way for future approaches to reverse this epidemic and create social change. But this shift really requires an interdisciplinary knowledge base. And Many of us who receive funding from the NIH and the CDC know that almost all the proposals we're submitting now are calling for interdisciplinary science. So it's not one group of investigators who are focused within one discipline, creating a hypothesis and driving forward. It's many different scientists working together. We're now at a point where we can connect. It's a global environment, and we're much better at solving complex problems when we combine our disciplines. And so integrating systems theory, which I try to do, with concepts and practice from community development, social ecology, social networks, public health, and more, is really what's required to reverse this complex and seemingly intractable epidemic. So for those of you who aren't aware that there's an obesity epidemic, I'm sure most of you are, I'm going to walk you through some historical data on children. I can share with you the adult data as well, but the focus tonight is really on pediatrics or childhood obesity. So these are national trends, and we have an ongoing research system in our country called NHANES. And that stands for National Health and Nutrition Examination Survey. And much of the population data that you hear reported on NPR or in the New York Times stating the prevalence of something comes from our NHANES database, because it's a nice cross-section of the United States. It's kind of a slice of America where we oversample different populations to get a good sense of the prevalence of many different things. And because we do this year after year, we have trend data as well. So these are childhood obesity rates, and we're looking at trends over time, categorized as 2 to 5-year-olds, so that's our preschool population, 6 to 11-year-olds, which is our elementary school population, and 12 to 19-year-olds, our teens, our middle school and high school population. And we started this work around the time I was born, in the early 1960s. And I remember being in grade school. I grew up in Massachusetts, and when I look at my photographs of my school pictures, or when I recall the kids in my classroom, about 4 to 5% of kids were obese, visibly obese. These are obesity trends. And you can see in the 2 to 5-year-olds, it's gone from 5% up to 10.4%, which represents a doubling in our preschool population in America over this approximately 45-year period. And you can really see that the dramatic increase happened where it jumps from 7% in purple to 12% in blue between about the late 1980s and the early to mid 1990s. In our elementary school population, it went from 4% to almost 20%, so a quadrupling. And in our teen population, from 5% to 18%, or tripling. So this is a very short period of time that we've seen dramatic increases in childhood obesity rates. So now you can look around at an elementary school and see about 20% or so of the kids being overweight or obese. Being obese. If you combine this with overweight children, which aren't always visibly detectable, but they're carrying too much weight and it's unhealthy, it's about 33% of children in America who are overweight or obese. Now, I work predominantly in disadvantaged communities, as I said, and it's not uncommon for me to go into a community and measure about 50% of the kids as overweight or obese. Now, if you go into a privileged community, you'll see it not 33%, but down around 15 to 20%. So there are clear disparities. It's a really good question. I'm happy to do that. So it's different for children and adults. We use the BMI measure, which is body mass index, for everyone. So the way that you do that is you measure height and weight, and it's weight in kilograms and height in meters squared. So it's a fairly simple equation that you get a single number from. And for adults, you want that body mass index to be between about 18.5 and 24.9. That's considered a normal, healthy range. Below 18.5, you're considered underweight, and a 25 or above, you're considered overweight or obese. 25 to 29.9 is overweight, and 30 or above is obese. So while we're on the topic of adults, 66% of adults in the U.S. have a body mass index greater than 25. And so for children, we calculate the BMI, but we use growth charts. And they're separate for males and females. unlike for adults, they're all the same, and they're based on your age. So you would plot a child on a growth chart and get a percentile. If you are between the 5th and the 85th percentile, you're considered healthy or normal. 85th to 95th is overweight, and 95th and above is obese. So what you're looking at now on this slide is the percentage of kids who are at or above the 85th percentile. So that includes overweight and obese together. And it's in here it looks like about 32, but the most recent was really closer to 33. At or above the 95th, which is combining that last slide, kids between 2 and 19 all together, you can see that it's about 17%. And at or above the 97th is about 11 to 12%. And those kids are candidates for treatment. So they should be in an obesity treatment program. They're carrying far too much weight, and generally they need a multidisciplinary approach. So a pediatrician who's trained in treatment, probably some sort of therapist to help the family along, and a dietitian. So unfortunately, we've seen a very big increase in that category of children at or above the 97th percentile. So if you haven't been to a pediatrician in a while, and if you have children of your own, when you were taking them, they were separate charts for height and weight. Now it's combined and it's one BMI chart. Some pediatricians will still give you the percentile for height and weight, and if they're very young, head circumference. But most of the time now, according to the Centers for Disease Control, there should be a BMI percentile ranking that you get, and that should be done every single well-child visit, and you can track a child and see their growth trajectory. And if you see a child start to drift up from the 85th up closer to the 90th, that's really time to intervene, not to wait till they get to the 95th and are diagnosed with obesity. So it's really prevention at multiple stages, not letting them rise above the 85th, making sure if they're creeping toward it, you intervene, and certainly if they go into that overweight category, that proactive strategies are implemented. So as I said, rates are disproportionately associated with a number of things. Number one is race ethnicity. Our highest percentages within the childhood population are Hispanic boys and African American girls. They present with the highest rates of obesity. There's also an association with income. So for income to poverty ratio, which is a calculation that we do, we see the higher the income, the lower the rates. No surprise, I'm sure. And lastly, there's a geographic relationship as well. So the rural children in America have the highest rates, followed by the urban children, and lastly the suburban children. And most often, if you go into the suburbs, you'll see higher income Caucasian children. So it really is all interrelated. It's hard to tease these things apart. And I don't want to give anyone the impression that it's one of these things that's driving it. It's really their social environment and the political context that in some ways is driving this. So why are we here? How did we get here in a short amount of time? I at this point, expect that none of you are thinking we had a genetic change in the past 40 years. That would be impossible. It's something about the environment that has really shifted, that has caused overeating and underactivity. And so this is a fairly simple way to highlight for you some of the critical things that have changed that we actually have trend data on. And I didn't include all my trend slides tonight, but I can assure you that for all of these, we've been collecting data over at least the last 2, sometimes 5 decades, and we have a sense of the trends, and they parallel what you see in the obesity trends. So starting with the plethora of low-cost, energy-dense foods, it's hard to avoid food. It's everywhere you go, from a gas station to the checkout counter. It's really everywhere, and for kids, it's ubiquitous now. Increased portion sizes. There have been a number of really interesting studies showing how things have dramatically changed with respect to portion sizes. And because we're all used to it, we don't see it as much. How many of you have traveled outside the country in the past couple of years? So you probably know when you came back, you saw all of a sudden coffee, instead of 6 ounces, become 20 ounces, and mega-sized muffins and bagels, and everything's just big, extra large, grande. We have very large food portions here. Our dinner plates have gotten larger over the years. And the one that I remember as a kid is my mom had muffin trays. She baked muffins, and they were pretty small. You can't find those anymore. They're the large muffin trays. And people have actually looked at cookware and ladle sizes, and everything's gotten bigger. So part of it is, again, back to not individual choice, but it's happening around you and you don't even realize it. And then this one I love, and I think you'll appreciate. There are some classic cookbooks where people have looked at them 30 years ago, and now same exact recipe, and it used to say makes 3 dozen cookies, and now it says makes 2 dozen cookies. So you wouldn't even think about the fact that it's telling you to make, right? So it's really interesting. So there's a lot that's changed that we're not aware of. Food advertising and marketing aimed at children is something that I'm very concerned about, and I'm going to share some slides with you that I think will be overwhelming in terms of the money that's spent trying to get children to gain brand loyalty at a young age and consume foods that are often not healthy for them. Sugar-sweetened beverage consumption, very high in this country. Predominantly carbonated beverages like soda, although you go into any store now and you see a new drink every time you go in. And it's just a new formulation of a sports drink or an energy drink that basically contains a lot of sugar. And that has resulted in a displacement of milk consumption. So the lines cross when you look at the data. Milk has gone down, soda's gone up. So the total fluid volume might not be different, but it's what kids are consuming, and the calorie intake is actually higher. People eat away from home more than ever now, and fast food eaters tend to consume more calories than people who eat at home. Children are saturated with media. It's hard to get them away from it now, and they're addicted to different forms of media, and when they're engaged with most media, they're more sedentary than playing outside and making a fort in the yard. Physical education and recess has been cut across the country. One community I worked in the Mississippi River Delta, had no PE at all and no recess at all. The kids were asked to do extra studying during their break time. And as you can imagine, that didn't go very well for these young kids who are in disadvantaged environments to begin with. So it was very unfortunate. But the performance level of the school academically had gotten so bad that the state took over, and that was their way to deal with it. Declines in spontaneous physical activity. I joked about the fort making, but it's true. A lot of kids don't go out and sort of roam in the yard. I have a colleague who refers to himself as a child as a free-range kid. Would go out, come back when the street lights come on. I did that. And now it's true. We're all worried about kids, and they just don't go out and roam and come back 6 hours later. And then we've changed the built environment quite a bit. We're fortunate in New England. We still have a lot of old towns with sidewalks. I live in Concord, Massachusetts, with a nice town center. I can walk to town, but a lot of suburban areas now have been laid out, and it's impossible to walk. You absolutely have to drive. So we've changed our built environment quite a bit. So these are some of the reasons that energy in has gone up and energy out has gone down in the life of a child. So this is showing you the reported total youth marketing expenditures by promotional activity group in millions of dollars. This is basically the money spent to market to children. And the food and beverage industry spends about $1.6 billion annually to market to children and adolescents. It's a tremendous investment that is made. And the reason is because marketing works. People buy products that they see advertised, and they're enticed to buy products. And a lot of it is actually done in traditional measured media, like television, still on Saturday mornings, for example. But there's all kinds of other ways now to market and advertise to children, between in-store, in-school. New media, which I'll show you in a moment, is really exploding right now as more kids have electronic devices. And that's a way to do it really inexpensively. Paid placement during the Super Bowl, for example, which a lot of kids watch, is very expensive. But you can put something out there viral on the internet and guarantee that thousands of kids get it within a couple of hours, if it's pretty cool, for free. Just the cost of what it took to create the ad. But you don't have to pay to distribute it anymore. So it's a very different environment now for advertising. So what do the food and beverage industry advertise? Well, restaurants are probably the biggest in terms of the exposure that kids see. They see ads for restaurants a lot, and it's predominantly fast food restaurants. But they also see ads for cereals and snacks and candy and beverages. And at the very bottom, you see that kind of plum color? Those are the ads for healthy foods. So the exposure is pretty low. And most kids between the ages of 2 and 17 see around 5,000 ads per year. So this is actually looking over time, just from the year 2002 to 2008 in different age categories. And one thing that's happened is there's been a push in this country to restrict advertising to very young children. It's not where it should be, and you might read quite a bit about it right now because there have been some guidelines proposed that companies will need to follow in marketing only healthy foods to kids. But there's been a little bit of improvement. So you see how it's dipped for 2 to 11-year-olds a little bit. The problem is they've just gotten more aggressive with 18 to 49-year-olds. And even though you might say a program is targeting an 18 to 49-year-old, I can tell you that my son, who's almost 12, watches the Red Sox, and he watches the Patriots, and he's seeing ads on that. So it's just a way to displace where the advertising is going. So this won't be a surprise if you have children or grandchildren, but in an extremely short period of time, kids have gained access to cell phones, laptops, iPods, MP3 players. Just from 2004 to 2009, the 8 to 18-year-olds who owned an iPod or an MP3 player went from 18% to 76%. I bet it's close to 85% now. Cell phones went from 40% to 66%, and laptops from 12 to 30%. Almost all children between 8 to 18 own at least 2 of these things. Again, easy to market to them. But also I want to touch on the fact that there's just a lot of media exposure because they have multiple devices and they always have it with them. And it's displacing active time and it's exposing them to advertising for unhealthy foods. So there's kind of a double whammy going on. Not to mention the fact that people tend to eat when they watch TV. How many people sit down, watch television, and never put something on their lap and eat it? We all do, right? And I'm even going to ask this. How many people have actually brought a box of something in with them? No one's going to raise their hand. You all portion it onto a plate. I know that. So that's what people do sometimes. If you're doing that every day, it's a real problem. So in 1999, the total amount of media exposure for 8 to 18-year-olds was about 7.5 hours, 2004, 8.5, and by 2009, it was over 10 hours per day. Now, the total media use was about 7.5 hours because 29% of that time is media multitasking. So it's actually counting for more, but it's really being done at the same time. So a child is watching TV while they're on their laptop, or they're on their cell phone and they're on their iPod at the same time. Or maybe they're driving a car and they're doing all three. The total amount of media exposure is different by race ethnicity. So you actually see in children of color that there's more media time. And this is very much related to the fact that a lot of these kids live in unsafe environments and they're staying home a lot more and watching television. I know around the greater Boston area, I know a lot of families who will say, I'm not going to let my kids out to play. I know they're safe when they're home and they watch more television. So it's a function of the environment they live in. And this is just one study amongst many. There are several reports that have been put out on media exposure. This is just one study. It was actually done out of Harvard by Jean Viesha and colleagues. And it was entitled, When Children Eat What They Watch, Impact of Television Viewing on Dietary Intake in Youth. So it was a prospective observational study over 9 months, and they measured diet, physical activity, and television viewing in children about 11 and a half years of age from Boston Public Schools. And they found that each hour of TV viewing was associated with an additional 167 calorie intake, and that each hour of TV viewing was associated with increased consumption of foods frequently advertised. So if you weren't convinced already that what's advertised sells, and most of those foods contribute more calories than we'd like in a children's diet. This is one study that demonstrates that. So what should we do about it? We should probably put some pretty serious restrictions like they do in other countries around the world. It's been a battle in the United States. So we have advertising that occurs. Some companies have taken it upon themselves to be part of a consortium that have adopted some voluntary standards, and they're definitely doing better. And I think in combination with that, companies have started to reformulate their foods. So this is an example, just one particular company, I'm not picking on them, it's just an example to show you in the amount of sugar in their sugar-sweetened cereals, and that they've actually reduced the amount of sugar from 2007 to 2010. So something like Cocoa Puffs in '07 had 12 grams per serving, now has 10 grams. So there's been quite a bit of reformulation that's happened. It needs to get better. And we still need to consider these foods as treat foods, but there's effort on the part of industry, and I think we have to acknowledge that and support them. And a lot of people talk about, voting with your fork, where you actually are concerned about what you're eating, and you get involved as a citizen, and you buy the products that create the consumer demand so the companies respond. So it's really a cycle. Yes?
That's also per serving.
Mm-hmm.
And serving sizes recommended are much smaller than what the kids actually eat at a serving.
You're absolutely right. So the new recommendations that have
Double.
Right. The new recommendations that have been put forth actually base the amount of sugar on the amount commonly consumed, not the serving size. And so it's actually a lot different. So I want to just take a minute and talk about some work I did that was published in 2001, where I worked with a few colleagues around the country to study 4 different models of social change: tobacco, recycling, seatbelts, and breastfeeding. And we wanted to dig deep into these social movements to understand what it took to realize the change. So although we're not where we want to be, fewer people smoke in America. There's no question about that. Way more people recycle. I'm sure when you were growing up, there weren't recycling bins around. There weren't seatbelts and car seats for children, and breastfeeding rates were pretty low back in the 50s and 60s, and as women started to go back to work. So we have seen some public health success in these areas. So what did it take to create this success? We did about a year-long investigation to try to extract some of the key elements, and we found that they were quite similar amongst these different social change movements. And I've taken these and applied them to obesity prevention. So I'll just show you what they are. They're pretty intuitive when you hear what they are. However, doing them at the same time is what really counts. If you just did one of these things, it probably wouldn't make a dent. But if you do them collectively, it's the collective impact of all these things that can result in a social change or social transformation. So the first is you need a crisis. People don't pay attention unless there's a crisis. So there are examples from all of these. The Surgeon General's report from the late 1960s on tobacco called for a crisis in America. Before that, people didn't know the consequences of tobacco the way they did when that report came out. And then there were a whole slew of things that followed that. Recycling, there was a seminal event in New York where there was this barge. Do you remember that? That was kind of floating around. That kind of resulted in what is now the green movement, but it was really just the beginning of people realizing we're going to run out of space to put our trash. We need to get more involved in reuse and recycling, and then the kids got involved, and it kind of started a whole movement. We have that now with obesity. I think most people are convinced we're at crisis level. The military readiness is impacted right now. There are many people who can't serve because of their weight. The healthcare costs, as you know, are in the billions, much of it due to the obesity rates. And I think the part that is the hardest for me when I go out and work with kids in the studies is the depression and the discrimination that they feel, and the teasing and the bullying that occurs. So overall, it's a pretty poor quality of life for a child who is overweight. You need to build on a sound scientific base, and there have been, the last couple of decades, a very big emphasis on generating a strong evidence base for the causes of obesity and the solutions for obesity. And that's what many of us are working to advance right now. you need spark plugs. You need people who will stand up and take charge, either as active citizens or physicians or journalists or parents. It doesn't matter. Anyone can serve as a spark plug. And all these events had pretty serious spark plugs that stood up and made a statement. Until about 2 years ago, we didn't even have anyone talking about it nationally, except when Oprah went through her big weight loss, it became a topic of conversation, but there really wasn't a national dialogue going on. I'll share with you the First Lady's campaign, which you may have heard of, called Let's Move. She's taken on childhood obesity. So we do have right now someone at the national level really taking this on and promoting gardening and better policies and parental engagement. Recognizing the importance of economics, it's really interesting. With all these other movements, there were really good economic modeling exercises done that helped to influence policy. We're just getting to that with obesity right now. We know what the healthcare costs will be 5, 10, 20 years from now from the modeling. We know what it takes to build a office building now, anticipating the amount of weight that each floor needs to hold because it's different. There are lots of different models that are being done, including when a company wants to relocate to a new community. What do you think they look at? Obesity rates of the high schoolers, because that's the workforce that's coming out. So they'll be looking at middle school and high school to see who's their workforce that's about to arrive, particularly in factory-oriented production. So there's a lot of modeling that's happening now, and it's very, very interesting to see it emerge, but it's new. Coalitions and advocacy are key for any of these things, and we're all applying it now to the obesity work, using government strategically, employing mass communication, creating environmental and policy changes, and developing a clear plan. So these are really the elements that led to the success of these other movements. Now, some of them had individual things like taxation for tobacco was extremely important. Incentives for recycling was extremely important. But overall, these characteristics were similar, and I'm trying to apply them to the work that I do. So I want to just take a minute and talk about what a systems-oriented approach is. It grows from the field of system science, which a lot of the work was done at MIT, and I've been working with a couple of public health systems scientists to help me think about the problem differently. It's been done in the UK really well. The US is starting to do it. So a systems-oriented approach is really developing an understanding of the whole system. That's really a critical first step in tackling any problem. And it recognizes that there's a complex, reciprocal, and interactive relationship between an individual and their environment. So we're nested within multiple levels of environment: your home, your community, your state, your country, the globe. And this complex, multifaceted etiology of obesity really necessitates comprehensive systematic studies. And these words are thrown around all the time in the field that I'm in. Things that are multi-level, multi-structural, multifactorial. It really just shows us it's really complex. You can't say to someone, you just need to eat better and move more. It doesn't work that way. It's a lot more complex. And taking a systems approach really highlights the importance of the circumstances in which an event occurs, or the context, in order to understand the potential implementation and impact. So the most important thing I think about a systems approach is it really maps things out visually for you. So I'm going to show you a map that was developed in the UK that was a map to show the determinants or the causes of obesity and the interrelationships between. So when I tell you it's complex, and there's a lot of science out there now helping us to understand what causes energy imbalance, more energy in, less energy out, you'll believe me when you see this spaghetti map, and you won't be able to read it at all. But what it shows you is all the factors that are working against us to actually encourage overconsumption and underactivity. So this is the map, and each one of these represents a different factor, and you can see how they're related. But here's the important thing. This is the core engine that we all have, the energy balance engine. So everything on this side represents energy in, and everything here is energy out. And then there's physiologic and psychologic things that are going on more at the biology level. And they're really represented right here. So it's not as easy as, well, people just need to know how to eat better. We need to change our food production system, the way we consume. We need to change the marketing to children, our physical activity environment, etc. So I've pulled out a couple of these just to give you a sense of what some of these things are. There's agricultural policies. So you're familiar with the Farm Bill, right? That's coming up again, and you can get involved as a citizen and have a voice in it so that we subsidize more fruits and vegetables, for example. There's transportation systems. We have a lot of money going toward public transportation in this country. It could be used even better. People need to speak up. Marketing to children, I've already shown you the data on that. We need better policies and regulations. I would argue they need to be mandatory or at least co-regulatory. Right now they're voluntary or non-existent. Food away from home, breastfeeding. There's a relationship between breastfeeding and the development of obesity, stress, and physical education. So these are just a few things pulled out to give you a sense of the determinants of energy balance and obesity and how complex it is to think about tackling any of these or a variety of these at the same time. So what I did is I conducted a study called Shape Up Somerville, and I started to work with the community about a decade ago to try to plan the study. It got funded by the Centers for Disease Control and Prevention. We did the 3-year study, and then I've continued to work with them over the last 5 years to get more funding in and to expand and sustain everything that was done during that project. So this is kind of a history, which I won't go through in detail, but it gives you a sense of when we actually wrote the social change paper and we wrote the grant, and then we got the grant, and this was the intervention period, and then a lot continued to happen afterwards. And the important thing here is that the trial was conducted as a community-based participatory trial, which means the community got involved, which is the title of the talk. So when you get the community involved, not researchers going in saying, here's what you should do, but researchers going in saying, what do you think we should do and how can we work together? That creates change that can be sustained over time. So it's a fairly well-known public health model, extremely hard to do because it involves relationship building and listening and trust. And that's time consuming and it's hard to get funding to do that kind of work. That's just human relationships, but it's hard to get funding. So it was successful. I'll show you the results. And then probably the biggest success was that it ended up at the White House. So it was a 3-year trial from 2002 to 2005. And as I said, it was a community-based, participatory, environmental approach to prevent obesity. So we focused on 1st through 3rd graders, 6 to 9-year-olds in Somerville and 2 control communities that were located outside Boston, very similar to Somerville in their socio-demographic breakdown. And the goal of the study that I wrote when I submitted it was to examine the effectiveness of this comprehensive community-based model on the prevention of undesirable weight gain in children. And that's really important to emphasize because all children are gaining weight every year. You don't want to prevent weight gain, you want to prevent undesirable weight gain. So a typical 7 or 8-year-old might gain 5 pounds a year if they're growing normally. What we're often seeing is kids gaining 10 to 15 pounds during that year. That's not what you want. So you want to prevent the undesirable weight gain. And the other goal was to transform this one community and inform social change at the national level. So Somerville, how many people have been to Somerville, Massachusetts? Many of you. So it is a densely populated urban community that's very, very diverse with not a lot of green space. And people often talk about it as the cut-through city, because I bet some of you have even done this. You're on 93 going to Boston and the traffic's backed up, so you get off and you cut through Somerville if you know your way around. So that means it's pretty congested, there's a lot of traffic, and when they paint the crosswalks, they're gone in about a month because of the heavy traffic flow, even trucks that aren't supposed to go through some of the streets. So that's the community we decided to target. And this is what a typical street looks like in Somerville. Why did we target it? Because Tufts University sits in Somerville and Medford. And so there was a long-standing relationship between Somerville and Tufts. And so we had a new president, and there was a new mayor, and it was time to bring those communities back together. And they had obesity rates of about 43% in the kids there. And so it was a perfect time to really try to work with that community. So what did we do? We worked with a community engagement model, which involved gathering information, mapping the community, participation assessment, identifying all the key partners, and building capacity. So it's everything I told you about, where it takes a lot of time and a lot of energy and a lot of trust building, but it's the way to really catalyze the community from the ground up. Because most changes that are sustained over time are both bottom up and top down. The top down changes are pretty hard to digest, and the bottom up changes don't get that top level support. So you really need to have both things going on at the same time. So I'm not going to spend a lot of time on these things around the edges, but these are all the things we did in the first year before we did one single intervention. We really talked to the community, we held meetings, we did environmental assessments, but as I mentioned already, we listened quite a bit. We really learned what this community was like, and we built relationships and established trust. And we had partnerships with all the community groups. So it was an academic community partnership. So what we were trying to do was increase energy expenditure and change the portfolio of foods that children were being presented with to make them healthier, and emphasizing foods that were low in fat and sugar, and foods that were fruits and vegetables and low-fat dairy and whole grains. We tried to increase opportunities for physical activity, we decreased screen time, and we encouraged family meals. And we did this through a multi-level approach. So we went in before school, during school, after school, into the homes and into the communities. And in this community, we had to translate into Spanish, Portuguese, and Haitian Creole. Those are the three most commonly spoken languages. It doesn't mean there aren't others spoken, but there's a large Haitian population and Brazilian, and then Hispanic population. So this is kind of the model of what we did. Kids go somewhere in the early morning. They either go to school for a breakfast program or they stay at home. Then they're in school for 6-7 hours a day. Then they go somewhere after school. They either go home or they go to an after school program. And so that kind of covers a big portion of waking time for kids. If they're not in these places, they're probably at home or out in the community somewhere, eating at a restaurant, engaging in a park and rec program, maybe walking down the street. So we spent a lot of time trying to design interventions that would target the waking hours that they were most commonly in, and then we had reinforcing environments where we did a whole lot with those environments as well. So there were multiple interventions going on at the same time. We had spark plugs engaged, we had local government engaged, we had environmental and policy interventions that we were trying to create. So we ended up working within the home with the parent, child, and family, within the school with the children, the teachers, the administration, and the staff, in the community at large with after-school programs, different ethnic groups, restaurants, with the healthcare system, which consisted of the pediatricians, the family physicians, and their nursing staff, the local government, and the local media. So we really targeted all the different systems within that community. And this just shows you some of the things we did. So when we first went to the community, typical school food program where the staff had box openers and can openers, but they didn't have a lot of knives and industrial-sized food processors and big mixing bowls, etc. So we worked with the food service director to transform the school breakfast and school lunch, and that was a very big part of the intervention. We did experiential learning. We have a separate paper on how we transform the school food service, and it's been a model throughout the country. Just as an example, this is some of the stuff that was there before, and then this was some of the stuff that was there after for the a la carte. This is the out-of-pocket money kids can use. We worked with the restaurants. We had them offer smaller portions, serve fruits and vegetables, offer low-fat dairy, highlight that they were Shape Up approved on their menu boards, in their windows. We had the mayor eat at all the restaurants. We featured him in the paper. And that was pretty successful because it was very visible, and then people wanted to go to the restaurant. So without going into a lot of detail, we had classroom curriculum, we had after-school curriculum, we trained all the medical professionals, we recruited restaurants, we had parent newsletters, community newsletters, we had a monthly piece in the newspaper. We recruited all the after-school programs to be part of the intervention. And I think the most important thing is we developed community-wide policies that are still in place today. And those really promoted and sustained the change over time. And those were things like the city budget for walkability. So installing speed bumps around the schools, bike racks around the schools, using thermoplastic for all the crosswalks, which is a heavier material that's reflective and doesn't fade away like paint does. So those are just some examples of policies and changes to budgets that were pretty significant and that have been sustained and expanded over time. So that increases walkability and bikeability in a community, making some streets one way at different times of the day so it's safer to walk to the school, enriching the crossing guard network, and then wellness policies throughout the community, particularly in the school system. Those are just some examples. So what did we see? We saw a reduction in the BMI Z-score. You asked, how do you measure this in kids? You get BMI, and then it's actually a Z-score that you calculate, which a Z-score is the deviation from the median. And so the 50th percentile would be a 0. And so that translates into a percentile ranking. But for the purposes of how we show our data, it's BMI Z-score. And so in the community of Somerville, which is here, this is the first year of the intervention, there was a decrease in the BMI Z-score compared to the two control communities that were combined, as shown here. So that was a significant reduction, and that's the paper that we published so far. Behind this are data that are in review right now, which is the remaining part of the intervention, showing that the intervention had a sustained effect over time, and in comparison to the control communities was lower compared to this, which actually became higher. So over the course of the whole intervention, we successfully prevented unnecessary weight gain in the intervention children compared to the control children by doing a multifaceted, community-based approach. I'm going to skip that. So it got published, and then President Obama got elected, and within about 5 months, the First Lady was making a decision about what she would champion over the course of her tenure as First Lady. And one of the things that was floating around was childhood obesity. So I was fortunate enough, along with a few other colleagues from around the country, to be invited to go brief her so that she could become better informed about childhood obesity and make a decision. And she also is a champion of military families, which you probably know, among other things, but those are her visible commitments. She decided to take it on, and then about 6 months later actually launched her campaign called Let's Move. And when she launched it, she invited 2 politicians to stand by her side, and one was the mayor of Somerville. So I got to go the behind closed doors scientific briefing, which was appropriate, and he got to go to the public nationally televised, which was appropriate. Shouldn't have been me. That's not why I went into this field to begin with. So I was thrilled. So I'm going to just do a quick check of the time here, because I did promise time for questions. I'm actually going to skip this. As much as I'd love to share it with you, I think it's more than we need to go into for tonight. So what I want to talk about is, what are the ingredients for success if you want to make change at the community level? The first thing is you need leadership. There's no question. You know from anything you've ever done, you need to be a leader in it, and you need to look to leaders. And while I have you as a captive audience, a phrase I use a lot is, parents are the policymakers in the home. And I fall prey to it myself sometimes, because it is hard to be an authority figure in the home and say no. but we live in an obesogenic environment. And if you don't say no to your kids or your grandchildren, they will overconsume and under-exercise. So it's okay to say no. And we've done a body of research now that we've contributed to on parenting styles and the relationship between parenting styles and obesity. And it's very clear that permissive parents end up with kids who are more overweight, as well as overly restrictive parents. So it can go either way, but you really have to say no. That's my point. And as hard as it is, I've chronicled the day in my children's lives when I didn't say no. They overconsumed by almost 500 calories. And that was over and above letting them have a treat, which is fine. Have an ice cream cone, but not an ice cream cone and a cupcake and 5 pieces of candy and a soda, because that adds up to discretionary calories that are over and above what a child needs. So that's, if you have the opportunity to say that to someone, it's parents are the policymakers in the home, and it goes for media and food as well. So let them have treats, but not overconsume. So leadership in the home. We had, local data that catalyzed the support. So if you have data at the local level, it's a heck of a lot more meaningful than me showing you those national data. They're interesting to look at, but it doesn't feel like it's in your backyard. So if you have local data that you can collect, it's really important. Building relationships, as I mentioned, is extremely important, and the way we do that is qualitative research. So we do focus groups and we do key informant interviews, and that builds relationships and creates buy-in. Community champions can be early adopters and set the example, like the mayor of Somerville did. Professional development is essential. We did a lot of professional development with the teachers and the community leaders and the after-school program leaders. And when I say professional development, it wasn't me coming and talking about pediatric nutrition. It was me coming and talking about what they wanted to hear about, which was cardiovascular disease and cancer prevention and menopause. They wanted to hear about things that were relevant for them. And we did a lot of development so that they could become role models and champions. Additional funding obviously helps. People taking ownership is really key through memorandums of agreement and understanding. Dedicated staff within city government. And the reason I talk about this is a lot of communities around the country will call me and say, we want to do this too, but it's all just volunteer. You need someone to be responsible. Even if it's one person that's paid half-time, you have to have that. Otherwise, everyone gets excited as a volunteer, and then everybody goes back to their regular life. And it's pretty hard to hold a coalition together without somebody being responsible. We had a task force that really was the umbrella initiative that has lived on to today. Multiple systems were involved, and the policy changes were key for sustainability. So in the last couple minutes, I just want to make you aware of what kinds of things you should be thinking about to make a difference in the energy balance of a child. The first is the recommendation for physical activity. It's 1 hour, 60 minutes or more of daily physical activity that's at least moderate. And most of the 1 or more hours should be moderate to vigorous. 3 days a week, they should be doing muscle strengthening activities. And I don't mean weightlifting with push-ups, sit-ups, jumping activities, and then 3 days a week should be bone strengthening activities, which is predominantly jumping and running, anything that's weight bearing. So not to say swimming and biking aren't good, but they're not really going to help your bones that much. Activities should be age appropriate, enjoyable, and often offer variety. And these were part of the first physical activity guidelines that were issued for Americans. It's a pretty thick report, and I co-authored the pediatric chapter. So that's how much activity kids should get a day. Very few kids are meeting that. Very, very few kids. And we know that from objective measures where we put accelerometers on them and actually measure their activity level. It's not self-report. So we need to do better at getting kids up and moving and create environments where they can be physically active. So if you want to think about the areas for kind of standards and policies that are based on national recommendations, kids should be getting at least 5 servings of fruits and vegetables per day. You probably know that. Most kids get 2.5. A lot of that comes from French fries and fruit juice. Whole grains should be at least half of your grains per day. Now, a lot of the reformulation has actually focused on whole grains, so that the consumption has gone up in the American diet. It's still not where it should be, but it's definitely better than it used to be. Trans fat, Fat content should really be monitored. That is associated with cardiovascular disease over time. And there have been a number of studies looking at children who are autopsied, and you can see plaque development at a very early age. So even though they might not be showing signs of cardiovascular disease, they may actually have the plaque development, and they may have hypertension. Added sugars is a big problem. So a study published this past year showed 40% of children's caloric intake is now coming from added sugars and solid fats. And that's basically processed food. So we need to get the sugar content down. One of the biggest contributors to added sugars are sugar-sweetened beverages. And that's predominantly carbonated soft drinks and those energy drinks and sports drinks that I talked about. Sodium is a very hot topic in the U.S. right now. We overconsume sodium. We're on a national plan right now to get it down over the next decade in a stealth way so that hopefully the population doesn't rebel. It's hard. If someone took the sodium out of your food, you're not going to like the way it tastes. And if you've been on a low sodium diet, you know that it's difficult to adjust because we have so much sodium in our food supply now. So we're moving in that direction, but we need to be very aware of it. After the age of 2, 1% or non-fat milk. Under the age of 2, they still need whole milk. But as soon as they hit that magical 2, unless there's a clinical reason, get them on skim milk or 1%. There's no reason to be over-consuming fat from dairy. Same amount of calcium and vitamin D and protein. Sugar-sweetened beverages and juice I talked about already. It should be 100% juice, and it never should be more than 6 ounces. 4 to 6 ounces is all a child needs. Screen time, less than 2 hours a day is really what kids should be doing, and absolutely no TV in the bedroom. That just shouldn't be let in. Once it's in, it's extremely difficult to take out. So just don't let it in the bedroom. Food as a reward is a bad pattern to get into. Celebrations should be really carefully constructed and not always food-based. Just be careful with kids around that or they'll start to accept it. Vending is something we should be very aware of because vending machines are everywhere. Get them out or get them to be healthy vending. You'd be amazed at how many public schools in the U.S. don't have public drinking water available. It's unbelievable. So kids don't have drinking water and they're actually serving sugar-sweetened beverages. Highly doubt it's a problem in the public schools here, but make sure there's available clean water for kids when they're on the sports field and when they're in the school because they're often dehydrated, and that's a big cause of headaches in kids. I talked about physical activity time and training and professional development. Be a role model as best you can. You know, we've seen amazing results when teachers step up and they start taking the soda off their own desk and bringing a piece of fruit in or bringing water in. Kids really want to be like their teachers, and they really look up to their teachers, their parents, their grandparents, so we all have to be active role models. I talked about advertising. If you're involved in fundraising, keep the food part of it to a minimum. You know, we tend to do a lot of fundraising with food, and there's quite a bit of assessment and monitoring that's going on, and it's probably not important unless you're involved in the workplace right now, but it's really good to do that because, as one of my colleagues would say, what gets measured gets done. So if we're not measuring something, you're often not focused on it. These are the most promising action steps for local governments. This is the local level, and this was an IOM report. I wasn't part of this one, published in 2009. And it's an excellent report if you want to download it. But it really talks about what should be done at the local level. Incentive programs to attract supermarkets and grocery stores to underserved neighborhoods, what we call food deserts. So providing tax credits, grant and loan programs, menu labeling in chain restaurants, nutrition standards for food and beverages in government-run or regulated settings. And to put that in simple terms, not letting unhealthy food into programs that are funded by the government and the tax dollars. Tax strategies to discourage consumption of foods and beverages with minimal nutritional value. Media campaigns to actually promote consistent healthy messages. Networks of sidewalks and street crossings. Community policing strategies to improve safety so people get out and walk. Safe routes to school programs so kids can walk to school. Safe, attractive parks and playgrounds, joint use of facilities agreements so schools aren't locked padlocked after hours, but kids can actually use those playgrounds. A lot of areas of the country, they're locked with barbed wire, so kids can't even access them. Regulatory policies mandating minimum play space within a certain acreage within a town. So these are things at the local level that can really be taken on by a local government and by a community to make a significant difference. So as I mentioned, the First Lady's Let's Move campaign is focused on helping parents make healthier choices, better food in schools, increasing physical activity. There was a presidential memorandum that was released about 15 months ago, creating a task force on childhood obesity, and there's a foundation that's been set up with funding from Robert Wood Johnson and Kellogg, and hopefully that foundation will live on and continue this legacy of healthier kids in America. So I believe that by capitalizing on the interconnectivity of the community, we'll foster self-sustaining change. And I'm happy to take any questions.